and my thanks to our tour for the invitation to this august university and this magnificent city. The title, Managing Expectations, is deliberate. What I will tell you is very light on data. You will learn nothing, and I hope this advances easily. So as I say, the data will be very minimal. It will be predominantly the Canadian perspective, particularly how we've evolved to this point in the treatment of multiple myeloma, and I will highlight modestly Canadian contributions to the management of myeloma. So on the left is what used to be my institution, the Royal Victoria Hospital. Now it looks nothing at all like that. It's a modern airport sort of looking building, but you still have your magnificent Collegium Maius. And I'm not sure if this advances, by pressing the arrow forward or backward. Yes, okay. So if Americans think of Canada at all, they have an image of a very peaceful, even boring country. And I don't know if you can see the little bubbles of speech, but many Americans envy us for certain liberties that we have in our progressive country. The girl on the up there speaks of making your own reproductive choices. That's largely an aphorism for contraception, abortion. The gentleman reclining in a chair speaks of legal weed, which is a slang for legalized cannabis. But I will focus on the boy with the dog on the surfboard who says he can get health care. And in Canada, we have, in Canada, we have a universal health care system that's provided through a single payer. Now, the Canada Health Act established a universal health care system with the objective of facilitating reasonable access to health services without financial or other barriers. Canada now is the 5th country in terms of per capita expenditure on health in the OECD. The US is leading, of course, with about $13,000 per annum per patient, and in Canada it's about half of that. So we are, relative to the Americans, financially constrained. We have less money per capita to pay for health care. This applies across the country, but the administration of healthcare is a provincial responsibility. So we have 10 provinces, as indicated by the maps, 3 territories, all with their own health budgets effectively, but with the unified mission of providing universal health care to everyone. So I'd like to start with a case history of a patient that I saw, and it's just to illustrate, not as a representative case, but to illustrate the evolution of the management of myeloma over the past decade. And it's a 47-year-old woman who presented in February, about a decade ago in 2010, with compression fracture of the T5 vertebra. Her serum free lambda was elevated at 7,600. She had low immunoglobulin. She was hypogammaglobulinemic. The bone marrow aspirate was extensively infiltrated by plasma cells. And FISH cytogenetics, we did not at that time do testing for change in 1q, either gains in chromosome 1 or loss, but she was negative for deletion 17p, 414, and 1416. And her beta-2 microglobulin was elevated. She was RISS at the time, stage 2. So this is a slide which only I can see, but I apologize for the great detail in it, but it reflects what's happened over the course of the past 10 years. When she was diagnosed in 2010, the possibility of third-line therapy essentially did not exist. She was treated with an autologous stem cell transplant after conditioning. Martezumib had just been introduced, so she got Martezumib and dexamethasone, had an autologous stem cell transplant, and had a complete response, which lasted for a number of years. She had progressive disease after 2 years. At that time, there was no maintenance with lenalidomide. In red are the clinical trials. We were fortunate, or she was fortunate, to be able to be enrolled on clinical trials. The first clinical trial that she was on was subsequently published in the New England Journal. It was the Tourmaline trial with ixazomib and Revlimid dexamethasone for relapsed disease. She progressed, received pomalidomide, dexamethasone subsequently. The next regimen that she received is one that's largely a Canadian regimen. Cybor-D was predominantly the experience of the Princess Margaret Hospital in collaboration with the Mayo Clinic, but that combination became the most popular regimen for the treatment of multiple myeloma across Canada. When she relapsed, she did have access to Ixazomib with minimal response. Then I can't read that particularly well, but she was subsequently treated with Carfilzomib, which is approved, and the idea that she's still alive now on a clinical trial with a stringent complete response on a BITE clinical trial, bispecific T-cell engaging antibody, is remarkable. So that she's 10 years or 12 years now post-diagnosis on her 8th line of treatment in a stringent complete response. She recently was hospitalized with COVID, has recovered from that. So this is not by any means representative of our experience, but does, I think, indicate what the progress has been in the treatment of multiple myeloma in this particular instance. So I just want to show what the Americans have in terms of available drugs as outlined by the NCCN guidelines, and perhaps David can say a word about those. But in Canada, this is a menu of all of the drugs that are potentially used in the treatment of myeloma, both in frontline therapy for transplant candidates, for maintenance therapy, and I'll quickly go through these slides, but indicate that in Canada, the first regimen, Martezumib, lenalidomide, dexamethasone, will be approved. It will be the frontline regimen for transplant candidates, and lenalidomide was approved in Canada, but the other regimens that you see are not. You can't see these well, but so I will go quickly through them. Elotuzumab, which is a potentially useful monoclonal antibody in the treatment of multiple myeloma, is not approved in Canada and will never be marketed in Canada. So all of the studies suggesting benefit from that particular antibody, which is different than the anti-CD38 antibodies, that will not be seen in Canada. And the same is true of Ixazomib and isatuximab. So isatuximab is another anti-CD38 antibody. We'll probably never see marketing in Canada, and Ixazomib we had available predominantly through a compassionate release program during the COVID epidemic. It was the most widely used proteasome inhibitor, but again, not likely to be funded in Canada. So I apologize for the dumbing down of this talk, but this is just an outline that you've already heard about our drug classes and the direction we're going in. So even though proteasome inhibitors and IMiDs are usually referred to as the backbones, corticosteroids, particularly dexamethasone, is almost invariably in any combination, whether it's a doublet or a triplet, but we never speak of dexamethasone-based therapy. It's just there. So these are the classes of drugs that are available to us. In Canada, we've moved from monotherapy of treatment of relapsed disease to doublets to triplets, and we're arrested there. We will probably never be able to fund quadruplet therapy. And so patients are now, if they're in a center with clinical trials, are at that point of relapse going to immunotherapy with either BiTEs or CAR T therapy. So I just wanted to review the history briefly of the Canadian contribution, if you will, to multiple myeloma. So on the upper left is Julian Adams, who's a Canadian undergraduate at McGill in Montreal, who then went to MIT, has a PhD in biochemistry. By no coincidence, the three gentlemen on the bottom received the Nobel Prize in Chemistry in 2004 for describing the ubiquitin proteasome degradation pathway. And on the right, or actually in the middle, is Dr. Ciechanover, whose name already suggests Polish origin. His parents emigrated from Poland in the 1920s. So he's an Israeli scientist, and the other two gentlemen shared the Nobel Prize. Julian Adams, up in the upper left, recognizing potential importance of that pathway. Do I have a pointer on this? Yes? No. Is credited with that molecule, which shows B is the boronic acid, it does have a pointer. Oh, this. No, no. So I've held it backwards. Okay. No, I don't think it'll. Oh, yes. Okay. So it was Julian Adams' idea to introduce boronic acid into this molecule as an inhibitor of the proteasome, and the rest. If I can fast. Sorry, back. So the clinical trials with Martezumib, or Velcade as it subsequently became, were threefold that I think were important. The first was a description by Paul Richardson, New England Journal of Medicine, of the efficacy of Martezumib in relapsed myeloma at a time when there was no standard of care for relapsed disease. Dexamethasone was effectively the only drug for patients who had failed alkylating agent therapy. So Martezumib, on a basis of phase 2 data, was approved and subsequently was integrated into other combinations. So the combination that was popularized for a long time was that of MPV or VMP, depending on how you ordered the alphabet. But that paper in Blood with Mary Victoria Mateos as the lead author became the standard of care for many patients based on that randomized clinical trial in previously untreated patients who were not transplant eligible. And then Dr. Haruso, sitting on the left, yes, to my left, described a regimen of Martezumib and dexamethasone as an induction regimen for patients to undergo high-dose therapy with autologous stem cell transplant. And at that time, again, there was no standard of care in terms of conditioning regimen, and VD became essentially our regimen that was used in this particular patient. So my life is made a lot easier, as I suspect many of yours is, by what are called pre-printed orders. I no longer have to remember dosaging or any associated therapies. On a computer screen, I tick off the name, the unique number, et cetera, and it gets printed out and the order is carried out. So Martezumib was approved in 2013 for induction in newly diagnosed multiple myeloma based on the trial that Dr. Haruso led, a HOVON trial at the time, and other study looking at VTD versus TD. Cyborg-D became the established regimen in Canada for induction pre-transplant, although there were no phase 3 data comparing that regimen to any other regimens in newly diagnosed multiple myeloma. Along came the second generation, if you will, of Carfilzomib, which had a different structure and a different irreversible binding potential and it was this study that led to the approval of Carfilzomib in Canada. So the Endeavor study demonstrated a higher complete response rate or a higher overall response rate for Carfilzomib compared to Martezumib in combination with dexamethasone, and clearly showing a difference in progression-free survival, and Carfilzomib was subsequently approved as KD in Canada. So that regimen we now have. The other Canadian contribution, if you will, was the Aspire study, led by Keith Stewart, who's now back in Canada at the Princess Margaret from the Mayo Clinic, and this was a study of KRD in relapsed myeloma, comparing Carfilzomib with Lendex to Lendex alone until progression. A large number of patients. A number had been previously exposed to lenalidomide, but not, by definition, lenalidomide refractory. And that study showed, again, a PFS benefit for the triplet, and to date, we do not have that triplet available in Canada. So despite a clear improvement in PFS in relapsed patients, KRD is not approved. KD is approved, and the Canadian variation on that is to add cyclophosphamide. So KCD is now our typical regimen used when Carfilzomib is given with dexamethasone. And this is where we stand with respect to current practice, likely to be approved across Canada. And this is the trial of daratumumab plus Lendex. This is the trial that was reported in New England Journal by Terry Facon and others. And that trial randomized patients to the RD versus Dara-RD combination until progression. And this has now become the regimen of preference for untreated multiple myeloma in patients non-transplant eligible. And we are seeing the approval of this regimen across the country as the initial therapy for untreated non-transplant patients. And this is I'm sorry for the print and the graphs, but you've seen these before. This is on the left, the IFM contribution to the study of VRD and our maintenance. On the right, the Dana-Farber and their collaborators. And that study you've already heard much about. So that will become our standard regimen for induction in transplant-eligible patients. The other Canadian contribution, if you will, this is the truly novel drug. Selinexor is a nuclear export inhibitor. Precisely why it works in myeloma, I don't think anyone really understands. But the cartoon shows that certain proteins are exported, which may be beneficial in the therapy of myeloma. And this study, I'll point out the Polish contribution. The first author on this paper is Polish. And this study became the basis of another regimen that we now have for relapsed multiple myeloma, which is all oral not all oral. It's weekly bortezomib dexamethasone with selinexor, which is oral. Selinexor as a single agent was associated with significant GI toxicity, a reputation or rap that was probably well deserved, but in combination with Velcade and dexamethasone is a much better tolerated regimen, and we will now have this as a treatment for patients standard in relapsed multiple myeloma in patients who've failed at least 2 other lines. So the algorithm now for multiple myeloma in Canada is quite complicated, and this shows you the trials that have led to the approval by Health Canada of these regimens. So across the top, in newly diagnosed transplant ineligible, people are still using VMP, but not very commonly. Cybor-D remains the regimen most widely used, but DRD, based on the MAIA study, will be approved across Canada as the standard of care for transplant non-eligible patients. In relapsed disease, although those regimens are approved, in point of fact, only KD, where do we have it? KD is used, but typically in combination with cyclophosphamide. DRD is widely used, DVD less commonly used, except in patients who've been on lenalidomide maintenance post-transplant and are perhaps exposed to Velcade, but are lenalidomide refractory, and so DVD is a regimen that is also widely used. This will not be seen. This is approved, but not funded and unlikely to be funded. And pomalidomide is funded with VD. And then in the 3rd and 4th line options, the choices become more restricted because patients have become refractory to lenalidomide and to bortezomib, and often to carfilzomib. We use carfilzomib at a dose of 70 milligrams per meter squared weekly for convenience, and there was a phase 2 study that was conducted in Canada looking at that combination. So some provinces, as pointed out, have access to compassionate use of selinexor. Belantamab has been studied in Canada, but increasingly we're looking at BiTEs rather than just anti-BCMA naked antibody. British Columbia, which is the most disciplined of provinces with respect to how people treat multiple myeloma, has a very straightforward algorithm, and they will change from Cybor-D to VRD, and len maintenance is standard indefinitely until progression. In transplant-eligible patients, VRD will likely be replaced by DARA-RD from the Maya trial, so that block will change. And at relapse, very few patients will actually undergo second autologous stem cell transplant and down that pathway with drugs that have been approved. Now, we all now belong to the same church with a seat in Oxford, and that's the Church or the Center for Evidence-Based Medicine. Actually, this was the hierarchy of evidence was originally a Canadian contribution described in a Canadian medical journal in 1979 by a task force on the periodic health examination to determine the effectiveness of particular intervention. So there are hierarchies of evidence, with randomized controlled clinical trials being at the highest level, and at the lowest level, case series or expert opinion. So the obviously randomized controlled trials are unbiased with less risk of systemic errors, and the rest is sort of explained in the next phrase or two as to why that's so. Balancing internal validity and what other variables are controlled so that only the tested intervention affects the outcome. So the definition of a trial population, this is in RCT, the reference population of the patients with diagnosis, but the available population are clearly those patients who are seen in centers that have clinical trials available, those randomized trials, and then further restricting the numbers are eligibility criteria and patients who are not included in trial. So the study population in a randomized clinical trial may not at all be representative of patients with that diagnosis. So the limitations of randomized clinical trials, although the highest level of evidence, is that they may not apply to a larger population of patients with that disease. So now we come to real-world evidence, a term that's become fairly common, and it's information on healthcare derived from multiple sources outside typical clinical research settings. Some of them have been shown with Artur's publications, and these are reviews of electronic health records, product and disease registries, and at least for sequential therapy, which is now the most challenging issue for patients with multiple myeloma, at least for funding agencies, sequential therapy will never be tested in a randomized clinical trial, so that all of the randomized trials that you've heard about are for a single intervention, typically in either untreated disease, newly diagnosed disease, or in disease that has had a number of lines of treatment, but never defining subsequent lines of therapy. So the funding agencies rely increasingly on so-called real-world experience, real-world evidence, but the limitations are the quality of data, which may be uncertain. But now publications related to real-world evidence are appearing in journals of high impact and repute. So one of the things that the Canadians have done, or can do, is we have too small a population to do randomized clinical trials in any setting compared to either the United States or Europe, where a population of 30 million, and it's difficult to do phase 3 clinical trials except in the context of global trials. So there's a Myeloma Canada Research Network, which has established a very good database, and from that database, a number of outcomes are looked at with respect to sequential therapies. So these are the publications related to that, and that's something that I think any group that's reasonably organized that can collect data and store that data can make a contribution in terms of what happens to patients in the real world. So this is my summary slide. In Canada, which is a, if you will, resource-constrained health system, most newly diagnosed patients with myeloma won't relapse for at least 5 years. So the median survival is now extended with first-line therapy to about 5 years for most patients. And there are continually evolving options for relapsed myeloma patients. What Canadians have done is, when we didn't have lenalidomide, we substituted cyclophosphamide as a potential immunomodulator, if you will, rather than a cytotoxic drug. So we've typically added cyclophosphamide to carfilzomib. The CyBorD regimen, which had been the standard of care for most patients, has been probably replaced across Canada by RVD based on the phase 3 trial. And DRD, based on the Maya trial, will become the standard induction regimen across Canada for transplant-ineligible patients. The algorithm for standard sequencing of therapy is obviously very challenging in the absence of good data. So that is what the funding agencies ask of myeloma doctors or organizations or advocacy groups to try to come up with some algorithm of first, second, third line, fourth line, and so on, but very difficult in the absence of good data. I think that may be the last slide. It is. So thank you for remaining, and if there are questions, I'll be happy.
Thank you very much, Dr. Shustik, showing us and telling us about Canadian contribution to the development of research and clinical studies in multiple myeloma patients. I am grateful that you mentioned my co-chairman name, Sebastian Grosicki, that he did his wonderful paper in selinexor. And I find out also that British Columbia is the best place in Canada to be treated with multiple myeloma. I remember if I emigrated to Canada and developed it's British Columbia the best.
I wouldn't say that. I would say British Columbia is the most organized in terms of direction and precisely defining what you can and cannot do. We have a little more anarchy in Quebec. There's a little more leeway in how we can use drugs. For instance, we can use drugs repeatedly, not insensibly, but in Ontario and British Columbia, if you've received daratumumab once, you will never receive it again. If you've received lenalidomide for whatever reason, you will not be able to use it. And the same was true of Velcade for a long time until it became generic, that if you got your Cyborg-D 4 cycles prior to transplant and then were transplanted, you would never be allowed to receive Velcade again. So it's better in that it's disciplined. It's a little more restrictive in terms of flexibility.
As Polish, we are usually complaining. That is probably our national habit. But actually, hearing your speech, we have actually found that the situation in Poland is not actually different much. One thing that we do not have access is, for a reason that I don't know fully, is lenalidomide maintenance. That is our problem. And without actually a clear vision that we will achieve this, despite the fact that the lenalidomide lost patent, so patent has expired. So the drug should be cheaper, but still we do not have, I mean, in Poland, the procedure for reimbursement is such that a company has to apply and has to provide a lot of papers, yes. And apparently they still do not consider this, that this will provide sufficient income to do this. Also, we do not use Cyborg as the induction treatment, but we use VTD. That is cyclophosphamide is replaced by thalidomide. And
anyway, Canada is much more bigger than Poland, although population is quite similar. So we welcome you and Canadian colleagues for our cooperation. I'm afraid the next talk is online, so we have to be strict in time. Sorry about that. Once again, thank you very much.